Dr. Offit, welcome to the show.
Thank you. My pleasure.
It's delighted to have you back on. You were with us in it's hard to believe, in March of 2020, and you made a prediction that we would know a lot more about this virus, 12 months from then or 18 months from then, and I think we do. Before we get into it, I want to introduce you for those of the members of the audience who don't know you. You're a pediatrician specializing in infectious diseases and an expert on vaccines and immunology and virology. You co-invented the rotavirus vaccine. You are professor of vaccinology and of pediatrics at the University of Pennsylvania, and the director of the Vaccine Education Center at the Children's Hospital of Philadelphia. You're a member of the NIH Group on Vaccines and a member of the FDA Vaccines and Related Biological Products Advisory Committee, the VRB PAC, that just met a couple of days ago to approve the emergency use authorization of the vaccine, the COVID vaccine for children aged 5 to 11. And we'll have a chance to talk about that. And then you authored many books, many very popular books, including the two most recent. In 2020, you published Overkill: When Modern Medicine Goes Too Far. And then just recently, in September of this year, a new book, You Bet Your Life: From Blood Transfusions to Mass Vaccination, The Long and Risky History of Medical Innovation. So I must tell you that I was surprised by the subtitle of the last book. You're known as a staunch advocate of vaccination. You're in a, you're engaged against the anti-vaxxers. The subtitle here seems to imply that you give ammunition to the anti-vaxxers by talking about the risky history of vaccines, but I'm sure that's not the case.
No, I'm just trying to acknowledge the fact that every innovation of the 9 innovations I talk about in this book, which have allowed us to live 30 years longer than we did 100 years ago, every one has been associated with a learning curve, a learning curve that is associated with a human price. There's a human price to pay for knowledge. That's always true. Even if you just look at this most recent study that we talked about, 2 days ago at the Vaccine Advisory Committee, it was a study of 5 to 11-year-olds. There were, 2,400 children, 1,600 got vaccine, 800 got placebo. There were 19 cases of COVID in that trial, 16 in the placebo group. So those 16 children suffered COVID, including fever, including high fever, because of a flip of a coin. So therefore we learned something. We learned about whether this vaccine worked in that age group, but at a price. And the biggest price for me in the book was associated with the polio vaccine. That trial, just as a brief story. I mean, 420,000 children got Jonas Salk's polio vaccine. 200,000 got placebo saltwater in the mid 1950s. And the vaccine was found to be effective and safe. And so when that announcement was made that it was safe and effective, I mean, that was a headline in every newspaper in the country, and church bells rang out, and synagogues had special prayer meetings, and department stores stopped while that announcement was made. And my mother cried. I remember all of that. And so how do we know it was effective? We knew it was effective because 16 children died of polio in that study, all in the vaccine group. We knew it was effective because 36 children were paralyzed in that study, 34 in the placebo group for the rest of their lives. I mean, these were the first and second graders in the 1950s. I mean, I was a first and second grader in the 1950s, but for the flip of a coin, those children could have lived long, fulfilling lives. And I just think that's what you don't realize is the price paid for knowledge. And as historian Michael Harris said, the history of drug regulation in the United States is built on tombstones. We always learn as we go, and people don't accept that. They think, oh, you know what? I'll just wait till the learning curve is over, but it's never over.
Right. No, that's absolutely, you're absolutely right. But I think we'll have a chance to talk about perhaps different ways in which the price can be paid, because you're absolutely right that there's always a cost and a trade-off. Before we get into this, because I think we'd love to talk about the meeting that you were in at the FDA just a couple of days ago. Just give us briefly your assessment of the impact of the vaccine currently on the pandemic, both in terms of its effectiveness, its safety profile, and then the question about transmission and boosters and these nuances that I think often get confused.
Right, big question. So here's what I would say. I think that our way out of this pandemic is immunity, either immunity induced by vaccination or immunity induced by natural infection, both of which I think offer protection against serious illness. The most recent sort of seroprevalence studies, which were just published in the last few days in the Journal of the American Medical Association, showed a seroprevalence in this country of about 80%. So 80% of people in this country have either been naturally infected, vaccinated, or both. Is that enough? We are starting to see the incidence of infection and hospitalization and death decline, but that's happened before. Plus, we're heading into winter, and this is basically a winter respiratory virus, so I wouldn't get too excited yet.
Mhm.
If you look at the two factors necessary to determine the level of herd immunity you need to stop the spread of the virus, which is basically the R naught, the contagiousness index, and the effectiveness of the vaccine, there's actually a formula for this. If you plug those numbers into the formula, you realize we're going to need to have about 90 to 95% of the population immune, either from natural infection or immunization, that will significantly slow the spread of this virus. But I think we may already be starting to see a herd effect. I mean, where you're seeing the disease right now is in pockets, in generally under-immunized pockets. But the highly immunized areas, there's much less transmission. So we are getting there.
Okay. Now, I suppose there's I mean, it's not a sharp division or distinction between pandemic versus endemic. How do we decide, or who decides, or is it sort of organically determined that, okay, we're past the pandemic phase and now we're in the endemic phase and we get used to it? Or
well, so this is a worldwide epidemic. That's clear. When do you go from epidemic to endemic situation in this country? It is a blurry line. It's true. I mean, and it really has to do largely with what you're willing to accept at some level. We accept flu. We accept influenza that could, a couple of years ago had 700,000 hospitalizations, 60,000 deaths. We accept that. We don't mask and social distance to prevent flu. But we could.
Right.
We just choose not to.
Right. Tell us a little bit about the distinction between. So we know that the vaccines are effective to prevent severe illness and hospitalization, for a long time, at least as far as we can tell, 6, 8, 9 months post immunization. But they don't prevent as well new infections from occurring after a certain point. And then hence the need for boosters, but there's a distinction between a booster and a third dose and what a third dose might do to the immunity. Can you clarify that for us? I think that's important.
So the question is, what's the goal of this vaccine? I think the reasonable goal for this vaccine, which we've been saying from the beginning, is to protect against serious illness, to protect against the kind of illness that causes you to seek a doctor's care or go to the hospital or go to the intensive care unit or die. That's the goal, prevent serious illness. These vaccines have done that. I mean, if you look from when these vaccines first rolled out till now, the CDC data, either published or presented, has consistently shown that you have high protection against serious illness, including the Delta variant, including all age groups. So we've met that criteria. And so therefore you don't need any booster dosing because we've met that criteria. The second issue then is, but isn't it true that over time neutralizing, and the reason, I'm going to take a step back, I think the reason that we've met that criteria is because all you need is immunological memory. To protect against severe disease, all you need is memory B cells.
B cells, right. Okay.
Yeah, and so because it takes a while to become seriously ill. It takes a couple of weeks to become seriously ill, which is plenty of time for activation and differentiation of your memory cells to become antibody secreting cells and protect you. For mild illness or asymptomatic illness, there you need sort of antibodies at the time that you're exposed if you're going to try and prevent or lessen that. And neutralizing antibodies will always fade over time. It's true for any vaccine. And so if you're saying, we don't accept asymptomatic illness, we don't accept mild symptomatic illness, which is true of no vaccine. I mean, there's no vaccine that's held to that standard. But if we're going to hold this vaccine to that standard, then you're going to need frequent boosting. So that's where this comes from. And the reason is that we just, obviously don't want to be able to accept contagiousness, because if you have a mildly symptomatic illness, you could still be contagious. And that's an issue if you work in a long-term care facility. But I think that the data for booster dosing, the data that shows that a booster dose matters in terms of preventing severe illness comes out of Israel for the 70 to 79-year-old, and that's it. Even for the 60 to 69-year-old, the data were not strong. That's it. So even though we do recommend booster dosing for the greater than 50-year-old who has a medical condition that puts them at high risk of serious disease, I don't see the evidence that says they should get a booster dose. Mm-hmm. I just think that when President Biden stood up at that podium in the middle of August and said, by September 20th, we're going to have booster doses for everybody over 16, he opened a door that has just gotten wider and wider over time without clear evidence for why we're doing it. I can tell you that at the hospital of the University of Pennsylvania, when we admit people with the COVID into the ICU, it's not because they haven't gotten a third dose. It's not because they haven't gotten any doses.
Right. Right.
Dr. Offit, could you explain for us why it is using one metric for booster dosing, meaning prevention against severe illness? Why isn't the same metric being used for children?
So for children, right now, children, the 16 to 17-year-old is recommended to receive 2 doses for Pfizer 30 micrograms. The 12 to 15-year-old, 2 doses. Now the 5 to 11-year-old, 2 doses. Will we need?
Yeah, but the endpoints for the trial were not severe illness. So
there was no severe illness. I mean, the trials were small enough that it was symptomatic illness. I mean, if you look at the 5 to 11 trial, those 16 children in the placebo were moderately ill.
Right. So but on the booster dosing, we want, you're agreeing that we'd like data that robustly shows protection against severe illness, and we're not going to accept, so what if neutralizing titers to antibodies go down? So what if you get some more cases? The case for boosters needs to be made by protection against severe illness, correct?
The protection, it's much easier to protect against severe illness than it is to protect against asymptomatic or mild illness. So in those trials of children where you see protection against mild illness or mildly symptomatic or moderately symptomatic, you can then feel confident that that's also going to protect against severe disease, but not the other way around.
I see. So it would not have been appropriate in your mind to run a trial that's powered in children to show the vaccine prevents against severe illness.
That's right. I think frankly, it's arguably unethical. I mean,
and the reason. Right, and that's what I want to get. That's what the great point is, because I think that's where there's a lot of confusion. And so why is it unethical? You brought up MISC before. Is that the primary issue? What is the risks to kids from COVID that would make a trial like that unethical?
I think that again, if you show that you can protect against mild or moderately symptomatic illness, you can feel comfortable that you are also going to protect against severe illness. So you don't need to do a trial that includes many children with severe illness to prove that. You've already proven that.
What if?
I'm sorry.
What if there is a? Sorry, can you hear me now?
Yes. But now you're
okay. What if there's a rate of, the myocarditis has come up obviously multiple times. What if there's a 1 in 5,000 or 1 in 10,000 rate of myocarditis? This matters because, of course, you have 28 million kids. So you're going to see, a rate
before we get
adverse
that,
events.
I think I want to, Anish, sorry to interrupt, because that's a very important question, but I want to maybe frame a little bit more generally what's happened, a couple of days ago when the FDA committee approved this EUA. So, Dr. Offit, as I mentioned in the introduction, you were part of that committee, it's an advisory committee. So the vaccine has not yet been approved for that age group 5 to 11, but the advisory committee has unanimously approved it. And an EUA is essentially it's a determination that has certain stipulations in it to allow a vaccine to be approved without the usual sort of bar of evidence that is typically placed, to confront the sponsor of a new product. So a lesser bar. So the question here is why is that indicated in the case of children? So that's kind of an epidemiological question. When we know that children in general have a much milder illness, so it doesn't mean that not all of them will. Clearly there's some of them who have severe illness. That's the point that Anish was making here. But in general, does the epidemiology justify an EUA if the goal of the vaccine is to protect that population? Do you understand what
yes.
The point of my question?
Okay. So what we're asked at the FDA, and the FDA is a regulatory body, it's not a recommending body. What the FDA is asked is we're being asked is, are the data sufficient to make you comfortable that the benefits of this vaccine clearly and definitively outweigh the risks for this age group. In what manner it gets recommended for the age group will be up to the CDC. All we're saying is that we think that that's true, and therefore the company can distribute that vaccine for that age group, depending on who is recommended to receive it. That's all. So, so for me, it's always true. I mean, it's never when do you know everything. You never know everything. The question is when do you know enough? So here's what we knew. We knew that for the 5 to 11-year-old, which is about, as you said, about 28 million people, children, that there have been about 1.9 million cases. There's been roughly 8,600 hospitalizations, 1/3 of which resulted in an intensive care unit admission. We knew there's been about 2,000 cases of multi-system inflammatory disease, which is primarily a disease of the 5 to 13-year-old with a sort of median at 9 years of age. And we knew that about 143 children had died. That we knew. We knew that we had a study of 2,400 children that showed that the vaccine was roughly 91% effective at preventing mild and moderate illness, which then made us feel very comfortable that it would also prevent severe illness. And regarding myocarditis, which is also part of this, because that's the safety part of this. I mean, what worried you about myocarditis, aside from the fact that it was a complete surprise. I mean, no one had expected that mRNA vaccines would cause myocarditis, but it does. And so what you found when you did the 16 plus study, 16 years of age plus, was it was primarily a disorder of the 16 to 25-year-old. It was the younger male primarily after the second dose that had that problem, not the older person. So you worried then when you went down to 12 to 15 years of age that it would be even a greater problem, which fortunately wasn't true. I mean, it's actually a lesser problem in the 12 to 15-year-old in data both in the United States and Israel. So that was reassuring. Also, the 5 to 11-year-old is going to get a lesser dose of the virus. So they'll get a 10 microgram dose instead of a 30 microgram dose. So that also was to some extent reassuring. And then more importantly, I think, is that classic myocarditis, you know, when, for example, a virus infects the heart muscle and reproduces itself in heart muscle cells and destroys the heart muscle cell, that's a serious illness. And it is primarily a post-pubertal phenomenon. It's really not a disease as much of the 5 to 11-year-old. So that's somewhat reassuring. But I wish we had a different name than myocarditis, because when you hear myocarditis, you know, inflammation of heart muscle, that never sounds good. And you can say mild as much as you want, but it still sounds bad. It sounds like a contradiction in terms, mild myocarditis. But it really, for at least for what we see in our hospital, is a transient, short-lived, self-resolving phenomenon. And when you give anti-inflammatories or you don't give anti-inflammatories, it seems to go away. They don't really have very high levels of troponin. They don't really have very high levels of BNP, suggesting there's not a lot of heart muscle damage. It's really picked up mostly on this gadolinium-enhanced MRI, which can be positive for a while. And I'm not sure what that means, and I'm sure there will over time be a spectrum of illness that's defined here that we haven't defined clearly yet. But I guess that's what made me feel better about all of that. And, you know, we see kids in our hospital. What I see the most in our hospital is actually multi-system inflammatory disease. That's what scares me the most. When people ask me what about this virus scares me the most, that's what scares me the most. I mean, name a respiratory virus that does this. I mean, what this virus does is it causes you to make an immune response against the endothelial cells that line blood vessels, causing vasculitis. And that's why when these kids come in 1 month after a trivial infection, often asymptomatic infection that was picked up serendipitously, no longer shedding virus, antibody positive, who have high fever, lung involvement, kidney, liver, heart involvement. I mean, it's a little frightening. And some of these kids go on to have more longer term symptoms. It's just, it's an unusual virus. That's the part of it that worries me.
Right. And that's where we arrive at the idea that, you know, if it's so high risk to kids, right? If MISC, as you're talking about, which is pretty scary, then it makes a lot of sense to have you know, you don't want to run a large trial where, you know, you have a placebo arm potentially getting lots and lots of MISC, right? That would be the thrust of the argument, correct?
Correct.
So MISC, of course, just for whoever's listening, again, it's not associated usually with active shedding of the virus when the kid is coming in, correct? It's usually
They're not shedding.
Right, they're not shedding. Right. Sorry. So they're seropositive. You know, if you check them, their IgG is positive. You know, there are, of course, multiple things in play. One thing is that this was first reported in England, correct? In London, this idea. Then, of course, we saw it here in the winter and fall in a worse way. I'm only bringing this up because in the most recent Delta thing that we've had in the last 2 months, the Delta kind of spike that we've had in the last 2 months, there has been a seeming now decoupling of MIS-C from having COVID, from having had COVID. Correct? We would expect, based on the CDC stuff, that we'd have a lot more MIS-C now, given how many kids were infected with COVID with Delta than we're seeing. Doesn't that raise some question about why that is? And given that the median age of MIC is 9, this doesn't reflect the fact that most of the 12 and up were vaccinated heading into these last few summer months. So it looks like, does that decoupling change that risk benefit at all? Because it seems like MIS-C is not as much of an issue now. And then it also raises the question about because we don't quite understand why it is MIS-C was happening. Is MIS-C happening because kids have been out of circulation for a long time and suddenly you re-expose them, and they start circulating, and then there's some phenomenon that happens? Meaning, how closely can we link it to COVID given all that?
It was certainly over the last, we've gone from 4,000 to something like 5,200 cases over the past sort of month, 2 months or so. So it's not gone. And when I was on service a couple of weeks ago, we had a handful of children with MIS-C. So you wonder at some level whether it's to some extent underdiagnosed, or at least underreported. So I'm not sure. I don't know.
It's anything.
Because I don't know the pathogenesis of MIS-C. Because the thing that worries me is, would you vaccinate a child who has already had MIS-C? Would you vaccinate them? You can't really answer that question because you don't know. I know that there have been a couple case reports of people with MIS-C got vaccinated, then had a recurrence of their MIS-C. So that's a little worrying. Again, we'll learn as we go here.
Yeah, on that, along those lines, I want to come back a little bit to that question of this EUA application by Pfizer for children. Now, it's a bit of an unusual situation because it's a pandemic, so there are hundreds of thousands or millions of kids being infected, but very few of them get really sick. So in absolute numbers, the death, 140 deaths, in the whole country, it's kind of small. And so how does the FDA decide that, yes, it's okay to lower the bar to accept a smaller trial and whatnot, when you have other, so imagine another childhood illness, and I don't know, maybe Kawasaki's, I don't know, type 1 diabetes, or
I think it's
I'm not sure, something else that currently, maybe kills or provides a lot more serious disability and perhaps death to children. I wonder if the FDA was asked to issue an EUA for those familiar diseases, would it not ask for a higher bar and a longer, safety data and that sort of thing? Whereas now we're making an exemption for COVID. You know what I'm saying? Is there a double standard, or is it sort of?
I don't think so. I think so. Flu kills typically between 775 to 150 children a year. The last couple of years, it was a little more than 150, like 170, 180, but nonetheless, in that age, in that group, we recommend a flu vaccine for all children over 6 months of age. So, and this virus kills more children than that virus does.
No, sure, but what was I don't know what the initial flu clinical trials, when the first flu vaccine was approved. Was it approved under an EUA, or was it approved under? There was a demand for a full-fledged, long-term, follow-up and large numbers, right? A large clinical trial.
It was in the 1940s.
Okay, all right. But perhaps we can go with something more recent.
We'll take meningococcus. Meningococcus is a bacteria that probably affects a few hundred people a year. A few hundred, about 10% will have mortality. A larger percent, maybe 15, 25% will have significant long-term sequelae. But that's not a common disease. It's an uncommon disease for which we have a vaccine. So my attitude on these things is, if children die, and in this age group, the 5 to 11-year-old age group, there were 2 reports. One said 94 2 days ago. The other one said 143. But let's assume more than 100. That if you can prevent it safely, then prevent it. And although myocarditis is a consequence that you worry about, at least to date, it doesn't look like that is a killer. How many people have died of myocarditis so far? None. Now a handful have died of the thrombosis with thrombocytopenia syndrome. I think it's about 6 at this point, but myocarditis so far, no.
So, I agree with you. I mean, I feel, I feel okay with the EUA authorization to give parents a choice. I mean, there are clearly some children who are obese and at risk and whatnot, and I think it's good for parents to have a choice to give. But I'm wondering to what extent we're pushing this the vaccine, and maybe we'll talk about it when we talk about mandates. Not so much for the sake of children per se, but for the sake of their role in the chain of transmission to the wider population. I mean, is that sort of a pressing concern that we need to sort of go ahead and vaccinate the children and the whole population just because it will, benefit others?
Well, it certainly, that will be a benefit. I mean, can children catch and transmit this disease to others? Yes. They're typically asymptomatic, so you don't know that they were infected. And when they're living in a multi-generational home, sure. And that was brought up a couple of days ago. I don't think you could ever make that case to parents. I mean, I don't think you can make the case for parents that you should vaccinate your child as a shield to protect older people.
Right.
I mean, well, James Hillworth actually brought that up a couple of days ago at our meeting, but that is not the case. I mean, that's not the case we're making. The case we're making is we're vaccinating children to protect children from a disease which can cause them to suffer and be hospitalized and die. That's the case we're making.
Okay, good. Well, let's talk about, I mean, in that case, what's your view on mandates? Because I mean, I think, it's on a lot of people's minds that once now these EUAs are have been passed, or if the FDA goes ahead and approves the vaccine, Governor Newsom in California has said that as soon as it's approved, I'm going to mandate it for all children, public and private schools, and that sort of thing. What is your view? I think you've defended mandates under certain circumstances in the past, and I'm wondering if you can tell us how you would view a vaccine mandate for COVID currently.
It's, first of all, I wish we had a different word than mandates, maybe like good health requirement. That sounds better. When we require vaccines for children for school entry, and we do, I mean, all 50 states have school entry requirements for vaccines. 6 states only have medical exemptions. All the others either have philosophical or religious exemptions, or both. It's to protect the child, and it was born in the 1950s, school mandates of the measles vaccine. Why measles? Because measles is highly contagious, and that contagious has happened in schools. That's going to happen here too. It is happening here. So do I think I think in a better world you shouldn't need mandates. In a better world, people will look at the data and say, obviously my child benefits from this vaccine, I'm going to get it. I mean, if I have children, but they're in their 20s now, but if they were between 5 and 11 years of age, I would vaccinate them without question. With this vaccine, I would. Having seen these data, I would vaccinate them, because I think they are at some risk. It's not the same kind of risk a older person is, right? Like 93% of the deaths from people over 55. This is a virus that kills older people, but it can occasionally kill children. And if 143 children have died over the last year and a half in that age group, some with misc, and you can prevent the disease safely, then present it. But it would be nice if there was a risk-free choice. There isn't. There's just a choice to take a different risk. I think a choice not to get a vaccine is a choice to take the greater risk. And the problem is, and the reason mandates exist, is you're also taking the risk for others. You're making a decision for others because it's a contagious disease. I mean, I think that if you ask parents, if there's a child in a classroom who has a peanut allergy, I don't think there's any parent that would say, you know what, it is my civil liberty it's my personal freedom to have my child eat a peanut butter and jelly sandwich in class. And if that person doesn't like it, then don't go to school. I don't think anybody would do that. They would recognize that child is at risk, and so they wouldn't put that child at greater risk. I don't see any difference between that and this. The only difference is that every child in the school is at risk of this virus and potentially being hurt by it. I mean, I guess we're all shaped by. Sorry.
Yeah, before Michelle answers that question in terms of the ethical issues that relate to that, what do you think about the fact that what the CDC reported in the VRB PAC presentation was that 42% of kids 5 to 11 have already had COVID, have recovered from COVID. Take that, then add on to the fact that 70% of folks that have severe illness may have had at least one comorbidity. So 30% or so have no comorbidities, right? Is it unreasonable with and then of course add in the fact that there's about, at least with Moderna, there may be a 1 in 5,000 risk in young kids I shouldn't say that, 1 in 5,000 risk reported in young men. With Pfizer, there may be a 1 in 10,000 risk of vaccine myocarditis. With the fact that we know that it's relatively self-limited, your EF recovers, your troponin bump is not as high as classical myocarditis. I get all that, but in faced with all of that, would it be unreasonable for a parent to say, okay, I have a young, healthy kid who's 6 years old. One, should we find out what his antibody status is prior to getting this? And two, even if he's negative, I'm willing to take the one in, the risk that's much, much smaller than the risk of myocarditis of him having a severe outcome.
Well, first of all, there have been no deaths associated with myocarditis, but there have been deaths associated with disease. That when you're admitted to the hospital, that 1/3 of the time you're going to be in the ICU. So the more serious risk is the disease. Now, if you told me that the pandemic is going to dramatically continue to go down, the numbers are going to continue to go down, that's a different story. But I'm not convinced, since we're heading into winter and this is basically a winter virus, and all these susceptible people are going to be in one place. And especially in communities where the transmission is high, I think that's a recipe for disaster. And answer your question about the Dr. Haver's presentation that 40% of people were seropositive, and you saw the Journal of the American Medical Association just looked at 1.5 blood donations to try and get a sense of the seroprevalence in the United States was about 80%, which is interesting. I do think that you could argue as a parent, look, my child was naturally infected. I think that natural infection protects my child against serious illness. And so I therefore don't want to get a vaccine. The problem with that argument is that if you're going to be in a classroom with other children and you know that the vaccine is not as good, as is true of all vaccines, against asymptomatic or mildly symptomatic illness, during which you could still shed. And you know that giving a vaccine, at least to older people in that Kentucky study, that if you vaccinate someone who was naturally infected, that you decrease their chance of having an infection over the next several months by about 2.5-fold. And that if you get a vaccine, that you actually broaden your immune response against these variants of concern. So it's not as good of an argument as long as you're going to be in school with all these other people, some of whom are going to be have the kind of comorbidities that put them at high risk, to say it's my right to get a mildly symptomatic infection, which is really what you're arguing for there.
Right.
Michelle?
So yeah, Dr. Offit, on the question. So actually clarify for me, I don't know for a fact, is the flu vaccine mandated in schools, or are there states or localities where the flu vaccine is mandated?
Right. So mandates are a local phenomenon. They're not.
Right.
They're not a national phenomenon.
So I'm familiar with measles. The MMR vaccine being mandated widely or broadly in many places.
It's different in different states and different localities. I mean, the CDC recommends vaccines. They don't mandate them, and then different states decide whether or not they're going to mandate one vaccine or another, largely based on kind of what resources they have.
Right. But again, I'm not sure. I mean, is the flu vaccine widely mandated? As far as you know?
I would guess not.
Yeah. Right. So here is, I mean, isn't that a bit of a again, you're not. I don't want to put words in your mouth, but I'm thinking about the current proposals to mandate the COVID vaccine for children. I mean, it seems, again, you could make the case for measles and whatnot, and perhaps for the flu as well, to mandate it just because it's a disease of children more so than COVID. So then I can't help but think that maybe there's the ulterior motive is to, as you said, to perhaps use the vaccination of children, use the mandates to shield the older population or others, which would be in my mind kind of ethically problematic.
Yeah, I don't think that's ever an argument you can make. I mean, first of all, I think you could reasonably mandate the flu vaccine for children. It certainly will protect them. I mean, children certainly get infected and are hospitalized by this virus, occasionally killed by the virus. The same argument. It's the same argument.
Right.
The only difference actually is this vaccine is probably better than the flu vaccine, which isn't a great vaccine. It's probably our least effective vaccine, but it does generally protect against death.
Right. But I mean, isn't there a point? I mean, if the risk for COVID is, relatively low, I mean, is there a point where, who decides how much risk? I mean, if the risk is very low, if most children are going to do okay with COVID, I mean, who decides? Because I mean, at the end of the day, if it's a mandate, then it's either the school board or the city or the state or perhaps even the federal government dictating for everybody what the level of risk is for children. And if really we're doing this for the children, for something that is not a disease of children by and large, I mean, it is in some cases.
But it is. I mean, I guess, again, I mean, I work in a children's hospital, so I mean, it's hard for me to hear that it's not that big of a deal for children when I watched, for example, when I was on service last time, you know, I watched a child who was unvaccinated, who was over 12, who could have been vaccinated, whose parents chose not to vaccinate him, nor were they vaccinated. And I'm in the room while he's being taken off his face mask, oxygen, and ventilated. And you look at the parents there, and they're in complete anguish because they're watching their child initially struggle for breath and now being put on a ventilator. This was hard enough last year when we didn't have a vaccine. Now we have a vaccine. And it just, in a better world, you shouldn't have to mandate. In a better world, those parents would realize that this vaccine could have prevented all of this, but didn't. And so then what do you do? I mean, do you let them say, look, this is my choice, and you let them make this choice? See, I'm also they have lived through the 1991 Philadelphia measles epidemic. Okay, that was the only time in this country, to my knowledge, that we ever had compulsory vaccination. I mean, mandatory vaccination is you're asked to get a vaccine. If you don't get a vaccine, then you pay some sort of societal price. You don't get to work the job you work at. You normally you'll get to you may go to the school you want to go to. You may have to wear masks or get testing or whatever it is. But that's mandatory. Compulsory vaccination, you're vaccinated whether you want to be or not. I would argue all children are vaccinated against their will. But in any case, what happened in Philadelphia in 1991, over a 3-month period, we had 1,400 cases of measles and 9 deaths from measles in our city. To put that in perspective, the year before that, there were 2,300 cases of measles in the United States. So 1,400 cases, 9 deaths, centered on 2 fundamentalist churches, both faith-healing churches that chose not to vaccinate their children. They had big families and big schools, and that was the epicenter. So 500 of the cases and 7 of the deaths were in that group. 900 of the cases and 2 of the deaths were in the surrounding community. And so we just basically moved along the line to push for ultimately compulsory vaccination of those children. Now, what those parents were doing was perfectly legal. We had a religious exemption to vaccines that had been on the book for 10 years. And the pastor of one of the churches, Faith Tabernacle, went to the American Civil Liberties Union and said, represent us, right? This is a group that's perfectly willing to represent unpopular causes. And that was an unpopular cause. I mean, Philadelphia was a fear destination. People canceled trips to the city. We vaccinated down to 6 months of age at that time. It was awful. Just one child after the next was dying. It was awful. I mean, our hospital was eventually overrun with just, seeing children in the emergency department with measles. So we had compulsory vaccination. And when they asked the ACLU to represent them, the ACLU refused and said, there's a quote I'll never forget. The woman who was the head of the Pennsylvania branch of the ACLU said, while you're at liberty to martyr yourself to your religion, you're not at liberty to martyr your child. And that ended it. And then they got vaccinated. And just as another thing in terms of mandates, because I think this is also sort of an interesting story, and this really affected me, was a few years ago I wrote a book that had a religious theme. It was called Bad Faith. And in that book, I interviewed a woman named Rita Swan, who was a Christian scientist, or faith healer, didn't vaccinate her children. When her son was 15 months old, he got bacterial meningitis. She chose prayer instead of antibiotics, and over 10 days watched him die. Then she went into the medical school library, read everything she could about bacterial meningitis. She was actually brilliant. She was a brilliant woman, but nonetheless a faith healer. And then she realized she'd been, in her words, duped by the Christian Science Church. What amazed me the most about that story was she vaccinated her dog. When I asked her why she vaccinated her dog, she said, because it was the law. I mean, it's like, we protect our animals more than we protect our children in some way.
Right. These are difficult things. So with the case of when you say you use the analogy of the peanut butter, of exposing kids to peanut butter. I mean, I think for the most part, what people who are refusing the vaccines, and I meet a lot of them, and actually right now mostly adults, not so much the kids, but mostly adults who don't want to get vaccinated. They just don't trust for some reason, and I don't know that it's their own fault, but they don't. There's a lot of distrust currently, a lot of societal distrust about the vaccines. Some of them have moral exemptions because of the vaccines manufacturer and its links to aborted fetuses from decades ago and whatnot. I mean, these are not necessarily things that you can argue on a scientific or utilitarian basis. I mean, a person who's unvaccinated is not at that moment posing a risk or a threat to anybody, right? I mean, it's only the infected that are a threat, right? The unvaccinated are just, they don't want the extra protection and they take a chance, but it's not an action that they take, as opposed to, frequently the example is like, well, we stop drunk drivers or people from driving drunk. That's different, because the drunk driver is actually driving or doing something that is immediately a risk to others. Whereas the unvaccinated person is, for all we get, a healthy person and not presently at risk for anyone. And so I think that, so to me, the analogy doesn't really hold to say that it's, we can force them because they are in imminent danger to others.
That's always, it's like, if you choose not to vaccinate your children, the odds are you get away with it. You do. I mean, the odds are that your child's not going to suffer these diseases because they're not all that common. But you might not. And if you don't, and especially remember that especially for children, most of the infection and spread is in the asymptomatic child. So you can't tell. And if you're going to try and prevent the other children in that classroom, I think that you should vaccinate people who are unvaccinated. And the point that Anish made before is a good one. We probably should distinguish the word unvaccinated from unprotected. Someone who's been naturally infected probably is protected at some level. And when they do these sort of vaccinated versus unvaccinated studies, it really should be vaccinated versus unprotected, because as you go forward in time, more and more people who are unvaccinated are naturally infected. And therefore your protective efficacy starts to look worse. It looks like it's waning when in fact your unvaccinated is really protected. So you need to, that's one mistake I think that's made the CDC.
Well, no, I mean, I think, Dr. Ramv, you make a very compelling argument. And I think speaking from the perspective of the pediatrician at the bedside who's watching, an unvaccinated child have an outcome that is terrible, is a really important perspective that pediatricians bring to the table that, that say adult cardiologists or most people really don't have, because these things are so rare, correct? But, going back to what Michelle was saying about trust, campaigns, public health campaigns, or these campaigns that in order to be successful, you need buy-in and you need to avoid pitfalls, right? You spoke well to this when we briefly talked about the dengue vaccine, right? And the rollout in the Philippines, correct? And how, you ended up, even though you had a vaccine rollout with dengue in the Philippines that resulted in probably net lower overall morbidity and mortality, right? What ended up happening, where you had, healthy kids having an issue, I think because of ADE, correct? We suspect that really created a significant backlash against vaccination in the wider community. And I think just the way things have gone about, meaning it would be nice if government officials, whether they be Republicans or Democrats, not, before you guys meet, not come out saying, okay, we are ready to vaccinate 5 to 11-year-olds, because then it kind of sets the stage to be like, is this really a process that we're allowing the science to work, or is this rushed? Is there pressure to do it? I think if they made the argument similar to the way you were making it right now, I think you'd have a much, much better shot of getting way more people to say, you know what, the best thing for my child is to get vaccinated. But you have these things where, you have folks forecasting what the FDA must do. I'm not saying that the Biden administration or whoever is saying that's what must happen, but it certainly gives you that flavor if they come out before boosters, if they come out before the 5 to 11, before the 5 to 11 thing, and come out and make statements saying we are ready to vaccinate everyone, we are ready to go. And then you are leaving open when you have these trials that are, I mean, the trial is presented at Verbi PAC was 2,500 or so kids, correct? When you have a trial that size, you of course may miss some rate of 1 in 6,000, 1 in 7,000, 1 in 8,000, right, of whatever. And if it turns out that we're wrong and that the winter months aren't, big time months in terms of disease, the MISC decoupling, is kind of happening in real time. Who knows if that stays? Who knows what happens? Underreporting, all that stuff applies. But if we're wrong, and it turns out that we have way more cases of some adverse event, whether it be myocarditis or whatever, versus MISC versus MIC or COVID-related disease and hospitalizations, then I think that may really blow up in our faces. Is that a reasonable summary?
Yeah. Here's what I would say though. I think when Dr. Oster, I think or Oster, his name was, the cardiologist who presented and went through the myocarditis story.
Right.
One term that he used was interesting to me. He called, the typical myocarditis, classic myocarditis, meaning, like virus-induced myocarditis, which made me think that maybe we should call vaccine-induced myocarditis light, just because that was classic. This is like light, right? Because that's what it is. It's not the same thing.
Yeah.
Because whenever we say the word, it just sends shivers down your spine, because we've all seen myocarditis in the hospital, classic myocarditis. But I think from the child's standpoint, and I guess as a pediatrician, I always see it from the child's standpoint, I would wish my parent would vaccinate me. And so when they don't, then that's the question. When do you cross the line where the government basically represents the interests of the child? When does that happen? And, certainly with the measles outbreaks in Philadelphia, that was the decision, that we felt that the parents, American jurisprudence basically assumes that the parent will look out for the best interest of the child, but that's not always true. Right. And when it's not true, then when does the government step in?
But I think the skepticism in part comes from that there's a lot of uncertainty, there's a lot of moving parts. You are absolutely right. I mean, and we should say it over and over again. Vax myocarditis. Dr. I forget his name, the pediatric cardiologist that presented at VRB-PAC, beautiful presentation talking about classic myocarditis and how classic myocarditis way worse. Interestingly, none of those classic myocarditis cases were caused by COVID because they had no cases in their single center trial. So they just didn't have any COVID myocarditis for whatever reason. We're also not seeing a lot of COVID adult myocarditis. We're seeing a lot of troponin release in the setting of critical illness. So that's great. MISC, the troponin bump with MISC is non-existent. Like I'm almost like, how the heck are pediatricians diagnosing MISC myocarditis if you have no troponin bump? It's probably LV dysfunction, I guess. But
no. The point being, MRIs, like gadolinium enhanced MRIs for the most part.
Yeah, but the interesting thing, again, he presented the fact that MISC, the follow-up data, is that they have no LGE, right? So the MISC myocarditis folks had no late gadolinium enhancement. The vaccine myocarditis folks have a higher troponin bump than do the MISC folks, but lower than the classic myocarditis folks. Anyway, long story short, I think the most important little graph he showed in terms of vax myocarditis is that the EF recovers so quickly, with vax myocarditis in the vast majority of cases. So yes, vax myocarditis should not be thought of as equivalent to classic myocarditis. No question about that. I just think that the size of the trial gives a lot of people and the kind of some of the political side of it in terms of the proclamations made before you guys have been meeting, makes folks and the uncertainty of like what's going to happen going down the line makes folks a little skeptical in terms of and of course this dose is 1/3, right? It's 30 micrograms. 30 micrograms is the normal dose, the adult dose, if you will. This is 10 micrograms in 2 divided doses. So it would be this idea that the question that ultimately was put to you all to answer, right? Like yes or no. Would it be better if there was some wiggle room in terms of allowing for checking prior infection, allowing, if you're a healthy child, recommend, why aren't there more? Why was there only one question? Meaning yes, no, is this approval? Because there are clearly a bunch of members on that 1701 panel or whatever that raised a number of different issues. But at the end of the day, the answer to the question of should we approve it or not, if it's just that one question, then yeah, everyone's going to answer yes. So does nuance get you more buy-in from the public?
But see, that's not our issue. Our issue is, do we think that the evidence, that the benefits of the vaccine, because we know what the disease incidence is in that age group, outweigh the risk? Okay. Because we know, at least from a small study, whether it works, and we know from all these other issues about what the likely rate of myocarditis is in that group. Do we know enough Not that we know everything. Did we know enough? And see, the issue of whether you could say substratified, let's just say that we'll
Right.
screen everybody who's 5 to 11 years of age. Those who are antibody positive don't necessarily need to get this. That we'll highlight the group most likely to be hospitalized. That's not our issue. That's the issue. That's the CDC. That's all them. And that's why when people were struggling with this, I felt like finally Dr. Monto and Dr. Cohn from the CDC, stepped up and said, look, this is what we're supposed to do here. This is what they do. And don't try and keep asking for another question. I'm glad Peter Marks didn't move forward on providing us another question. We would have never ended that meeting if that was true.
Well, I promise this is going to be my last question here as we wrap up. So one last consideration, because I encountered it commonly, and to me it sounds plausible and maybe worthy of respect. This notion, so it's hard to prove, and I don't think there's any strong scientific evidence for it, but there I don't know if it's still a valid theory in pediatrics. There was this question of, a theory as to why there's more asthma and allergy, these days. And then there was a thought that maybe kids, it had to do with exposure to pathogens, in kindergarten or preschool and whatnot. But I mean, I don't want to defend that particular theory, but the point is that there may be for some people a presumption. I mean, we live in a hostile environment, so nature can be harmful and hostile. But at the same time, there can be some immunological challenges that can be beneficial over the long term. And some people may, prefer to presume in favor of, taking a chance with an infection that is likely to not harm the child or the person, and because there might be a benefit. We don't know enough, and in the long term, we don't know enough. At the end of the day, what can happen to autoimmune diseases and things like that. I think it's very hard to prove scientifically, but at the same time, I think it's a plausible or reasonable position to have.
No, I think the hygiene hypothesis is fair. I mean, I think that you need to mature away from a Th2 bias that you're born with, which is, say, an allergic bias, to a Th1 response, which you get by being exposed to pathogens in the environment. Mm-hmm. There was an editorial, an op-ed piece in the New England Journal of Medicine years ago that was titled "Eat Dirt, Please." I think that sort of summed it up best. But this has nothing to do with vaccines. I mean, vaccines prevent only a handful of the diseases, the many, many diseases that children get. So I think the fact that we have a highly vaccinated population has nothing to do with why it is that we have more asthma and allergies. I mean, just look at the intestine of a developing world child. I know this well because of our rotavirus vaccine. I mean, when we did trials in the developing world, it was much harder to get an immune response in the developing world child than it was in a child in this country. And the main reason is because you have an intestine that has parasites there, an intestine that has toxin-producing bacteria there. I mean, that's the developing world gut is so much different than here, but has really little to do with the vaccines. That's not. I mean, maybe certainly sanitation, hygiene in the home. I think that's all true, but it's not because we prevented too many infections. I mean, it's never good to get an infection. I guess as an infectious disease specialist, I think that's a bad thing. And I don't know why Mother Nature has the cachet that she has. I don't know why the word natural is good. I'd like to know who her PR team is, because she's been trying to crawl out of the ocean into land.
Fair enough. We'll let you have the last word against Mother Nature, Dr. Offit. That was terrific. Thank you very much for joining us.
All right, guys. Take care. Nice seeing you.
Bye.